So I see some folks are trickling in. So I think we can go ahead and get started with our welcome. And then as people continue to join, they'll definitely be here for the bulk of our presentation, which is hearing from our research team. So welcome to our bi-monthly Research in Progress webinar series. I'm Carrington Lott. I'm the program manager at Systems for Action. And if you're not familiar with Systems for Action, we're a national research program office of the Robert Wood Johnson Foundation, and we're housed at the Colorado School of Public Health. And one of our goals at Systems for Action is to fund studies across the nation that test novel strategies for helping delivery systems and medical, social, and public services work better together with the goal of advancing health equity and population health outcomes. So our webinar series is a great opportunity for everyone to hear from the research studies that are being conducted through our program, and we get to hear about their experiences in conducting their study and get to learn a little bit more about what they're learning so far. So this research team that we're hearing from today is based at the City University of New York, and it's one of our newest projects, and this is their first time presenting in our webinar series on their project titled Multisector Task Sharing to Improve Mental Health in Harlem. So this was one of 3 research studies that was funded out of our call for proposals that we released in 2021 that had a really specific focused call for solutions to address what we call the wrong pocket problem. And all of these projects also had to have an explicit focus on racial equity. So if you're unfamiliar with this term, the wrong pocket problem, it essentially arises when organizations working together to implement a collective action solution to align systems have different allocations of resources, power, and influences, disproportionately fall on certain organizations while benefits accrue to different organizations. So this can create insufficient incentives to invest in the collaborative solution, which impacts sustainability and scalability. So when we hear from our research team today, they'll be telling you about their solution that they proposed in their research project. So before introducing our presenters, a couple of housekeeping items. We will be recording today's session, and we'll email that out to everyone that has registered for today, along with the PDF of today's slides. And we also are reserving about 15 minutes at the end of today's session for our question and answer section. So if any questions come up at any point during this webinar, please feel free to locate your Q&A box at the bottom of your Zoom screen, and you can enter your questions in there. So, be introducing our presenters here today. So we have Victoria No, who is an associate professor of community health and social sciences. She's the director for the Center of Innovation and Mental Health and the mental health director of the Center for Immigrant, Refugee, and Global Health, which is housed at the City University of New York Graduate School of Public Health and Health Policy. So she specializes in implementation strategies for mental health task sharing and the use of community participatory methods to increase access to evidence-based mental health interventions. We'll also be hearing from Malcolm Punter and their research team, who is the president and CEO of Harlem Congregations for Community Improvement, which is a nonprofit organization. So the nonprofit organization offers a variety of social services in addition to its real estate development activities. And part of Malcolm's responsibilities include the oversight of their Office of Health and Wellness Strategies, which was established to combat health disparities such as HIV, diabetes, and immunization coverage. And then we'll also be hearing from their team, Deborah Levine, who is the director of the City University of New York School of Public Health's Harlem Initiative, which is an initiative to address neighborhood service priorities to improve health and reduce health disparities throughout Harlem. So throughout her career, she's worked to apply capacity building and technical assistance to community-based organizations, national nonprofits, and houses of worship by implementing strategies that increase access to and utilization of health promotion, disease prevention, and risk and reduction avoidance services for racial and ethnic minority individuals. And then after we hear from the research team, we'll be hearing some commentary from Susan Bean, who is the executive medical director at Healthfirst. In her role at Healthfirst, she leads a team that collaborates with major healthcare delivery systems and with local and national policy experts on the design, implementation, and dissemination of innovative outcomes-focused models of care. So with that, I'm going to stop sharing my screen so the research team can share their screen and then tell us a little bit more about their research project.
Thank you. Thank you all. Thank you, Keratin, for the wonderful introduction, and thank you, RWJF, for funding us. I'm really thrilled that we got this, got this opportunity to launch this project. I'm honored and privileged to be working alongside Dr. Punter and Ms. Deborah Levine on this project as well. And I'll start with sharing a little bit about the aims of the project, as well as the funding that we got. So we were able to actually expand the goals of this project because we also got the NIH Transformative Research Grant, which also focuses on health disparities. And so I'll be talking about the project in its entirety. And I wanted to thank both for this, as well as CUNY for the support that they've given us. Both of these projects, both of these grant mechanisms support system transformation around health equity. And so we've been really able to deepen the work that we're doing in terms of involving more sites due to this funding, as well as adding research aims to this project. And then I'm going to hand it over to the wonderful Miss Deborah Levine, who has been central in helping us organize our partnerships. And she'll tell you a little bit about the work that we do in terms of the partnerships.
Thank you, Dr. No, and again, thank you all for joining us and giving us an opportunity to share what I consider is going to be and is a tremendous effort in our community to really utilize a leadership mobilization model. As you see here, our CAB alone and our partners are still growing. We have 29 organizations, and we are looking to make sure that we are bringing the best of the best to the table. We have our primary care, our mental health organizations, government organizations, our city. We have our elected officials being represented, our community boards. We're making sure that we have representation, along with our public housing partners that are at the table. You'll also notice that our faith-based institutions, our houses of worship, participate in this process. We want to make sure that the information we're gathering is from all aspects of our community, people who both use the services, provide the services, and system leaders. And this way we'll be able to share our research, the implementation, and hopefully replication in other places that could benefit from this kind of partnership. To continue this conversation, I'm going to turn it over to Dr. Punter, who I am so grateful that he took the chance to hear us out on this conversation around mental health. He's been a leader in the community for years around supporting mental health. So it's really an honor to be able to work with him on this project. Dr. Punter?
Thank you, Deborah Levine, and thank you, Dr. No, and thank you, RWJ Woods Foundation, for funding us, but also for providing us with the platform to publicly announce our study and research, as well as our community implementation. This effort is truly a participatory effort. It's a participatory research effort in that Harlem Congregations for Community Improvement, who an organization that I am proud to lead, which was created in 1986 in the iconic Harlem community of New York City. Many of you may know of Harlem in terms of the Harlem Renaissance, but those who live here and continue to work here know it for the Renaissance, but also know it for its decline of about a 30 to 40 year decline in terms of its built environment, its economic environment, as well as we've come to learn its healthcare delivery access and systems. HCCI has been operating since 1986. And we will represent the community-based organizations as part of this initiative. And the background and community needs are a lot and large. And this effort here with the Harlem Strong Initiative is a way to make some efforts to address some of the health disparities and that we found in the community. On behalf of our board of directors and the community, you know, we are honored to be amongst you, and I myself, as a third generation Harlem resident, and I still lived in the community with my family. I will lead the community advisory board as its chair. I will serve as its chair. And Ms. Levine spoke about all of the diverse groups, from elected officials to faith-based organizations to community-based organizations, as well as residents who live in public housing, will be represented on that community advisory board, in addition to the City University scientists and researchers and academics and leadership, as well as you will learn, Dr. Bean, who you will be introduced in during the course of this presentation. I would go on if you need me to kind of describe how our formative work has been conducted. So the formative work really was to discover in the community of Harlem, which I assume this is a national group of participants. So the Harlem community has a population of about 500,000 residents, and but that community is made of about four square miles. So that population is densely dispersed in a small area. And while traditionally, since the 1930s, it was African American and Hispanic community, it is happily we're changing and creating a more diverse community, and that has really been changed since the 2010 and then more recently 2020 census. But the African American Latino community of Harlem, we found that they suffer 3 times more than any other than their European counterparts in terms of impact of cases and deaths in COVID-19. So 2 to 3 times higher for Black and Latino communities, and that represents a large population of people in the Harlem community as it exists today. And then the depression and anxiety rates, CUNY researchers have found have increased 30 to 56% for Black and Latinos as compared to white Americans. And then HCCI as a housing provider, housing, we address one of the foundational security needs of social security needs of individual. But if you don't have a healthcare system that is equitable and that provides physical and mental health, then the social determinants will be skewed negatively in that regard for lack of access. So the low-income housing community that we represent, have 7 times, the rate of depression and anxiety compared to higher income individuals in the same geographical area. And Harlem itself is on the island of Manhattan. So just by representation of geographics, there's a disparity in and of itself in income that's really an outlier and drastic in and of itself. What we also discovered is that our resident surveys, the preliminary findings, is that some of these statistics are staggering. And this particular data was collected between April and September of 2021. But as you can note, almost 78% of residents in their mental health profile report feelings of being at risk for PTSD, right? Post-traumatic stress disorder. If they feel that themselves, about themselves, imagine, that the rates are probably higher if measured against, actual metrics. But PTSD, as you know, is sort of a phenomenon that we see in theaters of war. So people living in the Harlem community, particularly the Black, African American, and Latinos, are feeling like they are at war in terms of mental health. And then interpersonal violence is on the rise in densely populated cities all over the country. And in Harlem, if it was its own municipality, would be a city because by virtue of its population, 500,000 residents is larger than most cities throughout and maybe even most counties throughout the United States. So, interpersonal violence has risen. We believe that it is a public health emergency. And apparently, some of the residents we surveyed feel similar. And then other people feel housing insecurity, food insecurity, employment, childcare challenges. And then 86% endorse the fact that they have some sort of barrier to mental health access. And this is what the Harlem Strong initiative is designed to combat or find solutions to or provide recommendations for. The barriers to mental health care are many. The staggering access, again, to depicted graphically, 87% access to mental health care is a barrier. Trust of mental health providers is significant, and adequate transportation as well as just mental health care costs too much. So that is an economic barrier that we will try to address. And there are significant differences in the community districts that are represented in Harlem. Harlem is divided into 3 core community districts, community boards 9, 10, and 11. And there are differences in racial and demographic makeup, but it is still one Harlem community. We call it the Greater Harlem Community, and all of those community boards are invited by the Community Advisory Board to be represented and represent their constituents as well as what their community needs are for their district. So there's challenges, right? The system challenges lack of mental health capacity and knowledge. We know that from our formative study research that is evident. The healthcare system is complex in and of itself, and often is siloed and tailored to people according to their income. And the United States has been battling concepts of delivery of healthcare even recently over the last 20 years, how to provide the most Americans with resources. And that's also true in the microcosm of community neighborhoods. We also see there's lack of funding for community-based organizations to provide community-based services. And that's always a challenge. And HCCI, as a not-for-profit, realizes those challenges every day. And then we hope to find solutions by providing training and capacity to faith-based organizations and community-based organizations, and training their own staff or attracting staff to become community health workers, as well as community navigators or care coordination. And that's one of the aims that we'll talk about further in this presentation. And as you might know, as researchers and scientists, that there's always a lack of trust in low-income communities, and particularly ethnic minorities, in terms of the research process. There's volumes, of course, of literature on that issue and regulations that we're, as researchers, are bound by with respect to providing the research that is most effective but least harmful to the people that we serve. So lack of trust is a real issue, and community-based organizations can help with that because we are close to the community, and we can help with vetting some of those concerns that folks have. The most, as far as I'm concerned, the best and most accurate way to build trust is to be honest and forthright, and I think HCCI is represented as a vehicle to that. And the CUNY School of Public Health is not on an ivory tower. They actually are housed right in the community, central to the central business district of the neighborhood of Harlem on the iconic West 125th Street. So they also have some for lack of a better word, street credibility in terms of connecting with the community at large.
Thank you, Dr. Punter, for that great background and providing us with a rationale for why this work is so important. I'm going to start talking now about the specific aims of the research project. And as Dr. Punter mentioned earlier, the mental health crisis is real, it's present, and there are numerous system challenges to making mental health services available, not just in Harlem, but across the country and probably across the world. And so in order for us to do this work, in order for us to create this village of care around mental health and the needs around social determinants and healthcare, we felt that it was very important to guide this work using a multi-sectoral coalition to help us make sure that the community is partnered and engaged in the process, to help identify innovations and develop innovations that come from the community, and essentially to help transform the system and sustain the mental health integration. So our first aim is focused on developing a multi-sectoral coalition. The second aim is to do the developmental formative work that is needed so that our interventions can be responsive to the community, can be culturally appropriate, address the social justice issues, and also, tackle some of the complexities in mental health integration across multiple systems. And so that work involves identifying barriers and facilitators. We've already started some of this prior to us getting this funding. So we have a survey that we started with, but we'll continue with some qualitative work, as well as use of system design and system thinking exercises that we'll be doing in the formative phase. This will all lead to a community implementation plan, which we will use to guide the actual implementation across the different settings that we focus on. The third aim is our evaluation aim, and that is to develop and test the adaptive implementation strategies of this multi-sectoral community collaborative care model that we'll be implementing. And our two gateway settings will be low-income housing, which will be through HCCI and their network of low-income housing developments across Harlem. They run over 100 low-income housing developments in Harlem. And so we'll be selecting from those residential buildings. And then also primary care and FQHCs, which will be supported by Healthfirst. So we're very fortunate to have that partnership to help us engage the primary care network. And both of these settings will then be connected to the network of community-based organizations, which I'll talk about next in the next slide. So the evaluation consists of a smart randomized control study, which is essentially an adaptive approach at looking at multiple strategies. So we're doing two steps. The first step is to compare the multi-sector collaborative care model, which for shorthand is MCC. And then our control group is essentially education and resources. And so we're providing training on mental health task sharing and education and toolkits to help support sites to implement that. In the MCC model, we'll be supporting them through a collaborative, and there'll be many different community engaged activities that will be part of that. So we're basically comparing the impact of the community engagement and community collaboration in a coordinated care process versus basically training and technical assistance. The second step is really exciting for us. We'll be conducting doing crowdsourcing at the end of the year one to identify technology-based innovations that can be adopted in the community and that the community thinks is needed to support implementation. And so that will get added on in year two, and the add-on will be compared to the MCC model. So what's the added value of adding this technology over the coordinated collaborative? We'll be using a type 2 hybrid implementation effectiveness design, which basically means that we're going to be looking at both intervention effectiveness and implementation outcomes. And we'll use mixed methods, which means looking at qualitative and quantitative outcomes. We'll look at consumer mental health, social risk process of care. And then in terms of implementation, we're interested in knowing about changes in the provider knowledge, attitudes, and skills, as well as the degree to which aspects of the program reaches the community, is adopted by the community, and is implemented with high quality. And then thirdly, we'll also look at cost effectiveness of the 3 models. Next slide. This is our conceptual model. So basically this helps depict the multiple levels that we're targeting. We actually are using a variety of different strategies. So this is a multi-strategy, complex intervention that consists of having a community advisory board, which Dr. Punter will be leading to help us address the system level barriers. And we're also going to be engaged in a group model building exercise with community stakeholder who will be part of a stakeholder planning council, and they will help ensure that the work that we do is responsive to the needs in the community. We're also going to be creating an electronic hub, basically a virtual space, a virtual platform for the communication across the different types of providers and different types of organizations. And we hope that that will help increase linkage to care. In terms of the implementation supports we'll be providing to the gateway setting, one is they'll be getting care navigators, or we'll be training their care navigators on mental health task sharing, and we'll be using virtual trainings. There will be community planning, and then the technology implementation. And that will be to support the organizational level. So focused on like the specific settings, housing, community-based organizations, faith-based organizations, or houses of worship, primary care. What are the, we'll create specific or different community implementation plans for those different settings. And essentially this is to address the syndemics of mental health, social risk, and COVID-19. And you can see on the right-hand side are the outcomes that we hope to achieve. So at the top is basically, because of this collaborative, we think that having this collaborative network will increase the network's capacity, the mental health engagement across the network, and ensure greater linkage to care and sustainability for the model. For our, at the organizational level, we hope that the providers will have increased knowledge, attitudes, and mental health uptake and coordination of care, and that it's more cost effective, for the system to have this model. And lastly, that the consumers will have better mental health outcomes, socioeconomic risk will get reduced, health will improve, and quality of life, functioning, and process of care will also be improved through this coordination. Next slide, please. This is a slide to describe our implementation and intervention planning. So we have already started the needs assessment. We've conducted the resident survey, and we're now in the process of conducting surveys with the CBO leaders and providers, as well as FBO faith-based leaders. We're also going to be doing qualitative interviews with select group of stakeholders as well. We've also started mapping out the service system in Harlem. So looking at, all the community-based organizations in Harlem and what services they provide, so we can identify the strengths in the system as well as the gaps, and help support addressing the gaps in care. We're also going to be engaged in a group model building exercise where we'll convene the Community Stakeholder Planning Council to talk about the barriers and facilitators, as well as their preferences for service needs and implementation strategies. And we'll use a human-centered design process to help adapt the materials for the curriculum, for the intervention. So we'll have intervention toolkits along with forms and checklists and patient journeys or consumer journeys, as well as provider journeys, to help make sure that we understand the process and we are designing to be responsive to the actual needs in the community. We're also going to be engaging in crowdsourcing of the technology solution at the end of year 1, and that is in partnership with Firefly Innovation, which has been running hackathons for the last few years around mental health, actually, and so as well as other, as well as technology for other solutions, other areas as well. And then finally, all of this will accumulate into community implementation plans for housing settings, for health, CBOs, and for faith-based settings. So again, these are the 3 conditions, and you can see here that the education and resource, you provide the training, but is limited systematic coordination across the three, across the sectors. In the multi-sector collaborative care model, we'll have care navigators that will help support the coordination of care across the sectors, but also capacitate the sectors on mental health skills, mental health task sharing skills. And then of course the MCCD and technology includes the technology piece. Next slide, please. And here's a more detailed description of the education and resource we have as part of our initial plan. And so, first is introducing the community collaborative care model for mental health to the sites that are enrolled in the education and resource arm. They'll be trained on team-based models of care, how to conduct screenings for depression, anxiety, trauma, substance use, and social risk, how to provide psychoeducation about common mental health conditions, social risk, and COVID-19, stress management skills, how to provide referrals and support linkage to care. We'll also be talking a lot about provider self-care because that has surfaced as a very important issue that is largely unaddressed at this time. And then incorporate a trauma-informed care model. And the ENR sites will also get a Harlem-focused mental health community resource guide that will also be based off of our mapping work. And they'll get some limited technical assistance, but basically this training will be provided through a online platform through our eHub. And our MCC condition will get that plus enhanced education. So depending on what the community needs, we will add that to the education. The community health workers, will get supervision on their mental health task sharing skills. So they'll be supported in terms of, patient navigation, coordination of care, and then actual clinical and the clinical mental health skills as well. They will be supported after the supervision period, which is about 6 months. They'll be supported to be part of a community engaged learning collaborative so they can learn from each other and engage in a continuous quality improvement process to support the strengthening of the network and also to create a culture of continuous learning and a culture for adopting mental health innovations. And then lastly, the eHub will also help facilitate community sharing of resources in the community. We hope that this will help support the diffusion of the research as well as diffusion of information about resources in the community. So in order to address both the social determinants and mental health, we realized that we really needed a large network. And that large network involves housing, primary care, mental health, behavioral health sites, community-based social service sites, and also houses of worship. And we've already identified the number of sites available for us to recruit from the Harlem community, and we'll be starting that effort in probably around May to get ready for the study in June or July. So here's a little bit more about our design and our method. So we'll be recruiting 16 low-income housing and 16 primary care sites. So that's our first recruitment. And then they will nominate community-based organizations and FBOs that they work with to the study. And they'll be randomized in clusters. And so there'll be basically 16 MCC sites and 16 education and resource sites, made up of 8 housing, 8 primary care, as well as the 16 CBOs and FBOs that they nominated. And similarly for the control group as well. We expect to recruit about 200 direct service providers from this network. And we'll be evaluating outcomes for 640 consumers in step 1 and 320 consumers in step 2 for the technology piece. So our data sources will be, will consist of surveys as well as administrative data, claims data, and qualitative data. We'll triangulate this data in order to help us understand the impact of the program in terms of its effectiveness on consumers at 0, 6, and 12 months. And then in terms of implementation, we'll be looking at provider outcomes across a 2-year period, so 0, 6, 12, and 24 months. We'll also be looking at the reach of the program, the adoption of mental health integration skills, and the sustainability based on the 2-year follow-up. And then, of course, the cost effectiveness. And so this is our timeline. Basically, we're now in the formative phase, and we'll be doing that actually until June-ish. And then we'll start with the provider baseline survey at the beginning of before the training actually starts. In year 2, we'll be strengthening the eHub and incorporating more of that into the project. We'll be engaged in supervision, the learning collaborative, and then start the consumer outcome study at that point. And then also the technology development will happen at that point as well. Year 3, we'll be starting the second step of the randomized control study with the technology and evaluating the later time points for the providers and the consumers, as well as launching the baseline for the technology. And then we'll wrap that up in year 4. And in year 5, we'll be continuing the effort to help sustain the model, as well as really putting more effort into dissemination and working across the system, especially with the system leaders, and the CAB will help lead us to help ensure that the work is sustained, and hopefully we'll be able to help support the dissemination of this across other areas in New York or other places. Now I'll pass it out to Deborah Levine, who will share about all of the dissemination efforts that will be part of this project.
Thank you, Dr. No. So as you've heard, this is a really powerful model and a powerful project. So one of the things that I think you've heard through the theme has been transparency, 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 sharing information, creating safe spaces. And so our dissemination plan is really based on that. As you can see from the model here, our goal is really to make sure that all of the information that we gather and is disseminated out to the very different sectors of our community. So to ensure that that conversation is going on, you'll see that it's going through our Harlem Strong Coalition Network, where there'll be an exchange of information. There is the Harlem Strong eHub, which is going to be this platform where we'll be able to share communication with our community stakeholders. We'll be able to create a space where data can be used and shared and diffusion of our research. And this will all be centered around a community-friendly model. Part of our dissemination also is ensuring that we are bringing this information step by step back to our community. And the way that we are doing that is using our community boards in the community of Harlem, community boards 9, 10, and 11, where we are bringing updates and sharing our steps in the Health and Human Services subcommittees, and also with the general boards themselves. Along with also working with other academic institutions in the community to share information around building this platform, lessons learned, community norms. You'll see also that we have listed publications and conferences, because we want to make sure that, again, not only are we disseminating this information to our community stakeholders and our residents and our systems, but we also want to be able to share this information with other public health professionals across the country. You'll see that we also want to engage, and will continue to engage in coalitions that, and working with our community government partners and system partners, so that our information, as it continues to grow, can be shared and can help also with our elected officials as they are working around pieces of legislation that support mental health initiatives in our community. So our goal is really around dissemination, is making sure that we are continuing to keep the information going out as information is coming in. And our eHub is going to be a great example of how that information happens. Next slide. And so system transformation. As you can see, this is really a neighborhood-based solution to address the systemics of the COVID-19, mental health, social risk, and institutional racism. It's a community-led, multi-sector collaborative, really centering community. You heard us talk before about bringing the leaders together, making sure that not only did we have our academic partners and friends, government, institutions and systems, Healthfirst at the table, our FQHCs, and our residents, but we really wanted to make sure that we heard all of those voices and that we were able to provide a really community-centered approach in this work. You'll see that the integration of mental health task sharing is a gateway for our settings, working with our houses of worship, our community-based organizations, best practices in human-centered design strategies, implementation of science and system science with our community stakeholders, crowdsourcing tools with our community. This for us is really going to be a model and utilizing our strategic partnerships to create something that is really going to strengthen the infrastructure in our Harlem community. And finally, the inclusion of Healthfirst as a managed care organization and DOH-MH as key collaborators in the model design and co-investigators will facilitate and adopt the sustainability of this model. So we are super, super excited about this work, about the partnerships, and are really looking forward to being able to share our outcomes in the journey as we move forward. Thank you very much. Dr. Bean, I'd like to introduce and turn the floor over to Dr. Bean to carry us through the next part of this presentation.
Thank you, Deborah. And thank you also to Dr. No, Dr. Punter, and the whole team for allowing Healthfirst to participate. I think that the Healthfirst became interested in this kind of work basically because of the disruption in access and engagement in care that occurred because of the pandemic, the ongoing pandemic. Realizing that we were going to have a disrupted structure of care, if you will, we began to look at other models of response to disaster and how we might need to plan in advance for changes that we would make so that in future potential events that are disastrous for our members and their communities, we could be prepared. And just to know, for you to know a little bit about Healthfirst, we are a Medicaid and Medicare Advantage and health exchange managed care organization serving about 1.5 million members in the New York City region, including Long Island and Hudson Valley. And so Harlem is actually one of the centers of where we're lucky to find many people pick us as an insurer. We became really interested, however, in what we could do in a preventive way as well as in a responsive way to the mental health needs of our members. And in this context, we were so happy to speak with Deborah Levine, and she led us to Dr. No. And Dr. No in particular is actually was part of the team that took a look at the results of Hurricane Katrina, her expertise is really around changing structure of care. And at Healthfirst, we felt that that was going to be not only important, but necessary, that this was an opportunity for us to open our eyes to a new way that care could be delivered to the most vulnerable populations and then across all of our populations. So we were going to take this intersection of time in terms of the ongoing pandemic and our relationship with the CUNY School of Public Health and others as a springboard to potentially find new ways of delivering mental health care to our members. And you saw in the data that Dr. Punter presented that when the residents of Harlem were surveyed, about 86% endorsed the fact that there were barriers to receiving the kind of help that they needed for mental health. But I think what was especially alarming to me and to Healthfirst is that about the same percentage said that the main issue was access to services. And so this kind of initiative is vital, if you will, to the well-being of the populations, not only that we serve, but also to their communities. So why would a managed care organization need a collaboration like this? And many look at managed care as if we just wave our magic wand and benefits and all of a sudden everything is fixed. So that's not really true. And that's, I think, I'll share 4 or 5 reasons that I think this kind of project is so critical and why we're so grateful to RWJ and NIH for funding it. First of all, there's no question that we would not know that 87% of our community is saying that they have barriers to access care, specifically mental health care, without participatory research. In other words, we at best are thinking mainly about our members. Even better, at Healthfirst, we do attempt to engage the community, but this project really speaks to us about the voice of the community. In other words, we're not putting words in people's mouths or services in their access framework without hearing their voice and letting their voice, frankly, be the most powerful voice at the table. Speaking of power, I think that this project is really important in terms of giving people power in a situation where they must be potentially the most vulnerable in terms of sharing their emotions, their mental health, their social and other kinds of instabilities with a healthcare delivery system that, as Dr. Punter said, they may not truly trust. So power, we find that in navigation and community health workers, power is transferred from the seat of the doctor or the healthcare delivery system to the person who is attempting to have their needs met. And then thirdly, we have to talk about structural change to address institutional racism and all the other kinds of isms. I mean, quite frankly, we are fooling ourselves that if we don't change the equation in terms of how healthcare is structured, that an awesome team that you just heard speak would be able to do this on their own on behalf of the community. So the role of Healthfirst is really to use our levers, if you will, to change the structure of how first our members and then communities and New Yorkers and hopefully other communities can begin to experience the answer to the needs and goals that people are setting. So to be part of that structural change, Healthfirst takes seriously our responsibility and commitment to the education of the providers through these community vehicles, to helping them understand that some power will be shifted in this way, and to making it a holistic model so that people are not getting their brain, have to put their brain in this room and their body in another room in order to have their all of their chronic conditions managed. And then finally, the last thing I would say is that there's some prevention built in here as well. So, you know, we at Healthfirst really want to find ways to transition from being an illness model to a true prevention model, where we're not studying to some particular metric test, but rather we are helping people who trust us and who trust our collaborators to actually help them live healthier lives so that they never potentially need all the kinds of services that they're frustrated in trying to access and engage. So with that, I thank you for the opportunity to share a few observations, and I turn the podium back to Systems for Action.
We're heading into our Q&A portion here. So let me share my screen here. And while I'm doing that, just thank you again for the team for updating us on what they're planning to do over these next couple of years with their project. And thank you so much to Dr. Bean for providing some insight on the value of this research for your MCO and for the community at large. So we have about 9 minutes for questions, and I see that some have trickled in, so we'll try to get to all these, but I do invite you, if you have any other questions, please enter it into the Q&A. If we don't have time to get to it today, we always do share the questions that we didn't have time to address with the research team and give them the opportunity to address those. So don't let the time sway you from entering in your question. So we'll go ahead and get started here with our first question from Elena. And their question is, the care coordination is a valuable component of the multi-sector enhanced services, and I presume care coordinators are funded through the grant. Is there any thought of how to sustain funding for these important care coordinator positions past the life of the grant funding?
So if I may, I'll take that one, Dr. No. Yeah, so part of the role of Healthfirst as an MCO in New York State is to find ways to deliver social determinant help to our members. And this is an initiative that is throughout New York State. Healthfirst takes this very seriously, and we are excited to be part of the sustainability portion of the grant and to find innovative ways, some of which we've tested, to support care navigation and coordination beyond the life of the grant. So more to come on that.
Thank you, Dr. Bean. Anything else from anybody on the research team?
Sure. So yeah, the sustainability of that is critical, and having Healthfirst at the table leading in that way has been so great for the project. But in terms of how we're funding it now, funding is often not enough with pretty much everything, and so we're patching together funding and identifying also sites that already have care navigators, as well as funding navigators for sites that don't have navigators. And the third thing we'll be doing is training CUNY SPH students to support the care navigation process and create a fieldwork experience for them where they can then be placed in community-based organizations. They get training to do community work, the sites get support. And that's one of the things that surfaced from some of the earlier, engagement meetings that we had with CBOs, is they said they need more support. And so we're going to try to find different ways to piece this together.
Dr. No, I just want to mention that, if I can, one of the benefits that HCCI and other faith-based and community-based organizations are receiving is the training for their case managers to be cross-trained as community health workers. So in our instance, our case managers are already hired. They are funded through other sources to provide other types of services. But with this training and capacity building effort, they will be able to also provide the community health worker navigation services to the community. So they'll be sustained otherwise through their own program and funding source, but they'll be trained through this particular effort, thereby sustaining both.
Great. Thank you all for providing your insight on that. I think you've been creative and intentional in terms of how you can continue to sustain those workers. So our next question comes from Michelle. Has the research group given any thoughts to differences among the community health workers assigned to the MCC and the MCC plus conditions? Will they be matched in any way? One more is the technology added a community resource referral technology system or a case management system. So it sounds like those are two separate questions if you want to address maybe one at a time.
Yeah, so the community health workers will be the same community health workers because they'll be the same sites that got the MCC. It's just that after a year of implementing, the network will decide on which innovation they want to adopt and make widespread. And so then we'll support that innovation. So it might be a client management system for CBOs. It might be, you know, a referral mechanism, you know, that can be put into the eHub that can be used across all sites, but it's the same care managers that are part of the project throughout. So some sites will have the technology and some sites won't, but the care managers remain the same, if that makes sense.
Move on to our next question from Bailey. How will cost effectiveness and savings be assessed? Just a moment, that's get right on my screen. Okay, will it be calculated for individuals, health housing providers, or at a community level?
At present, it is focused on providers. So looking at, you know, the cost of engaging all the different types of providers, the cost of participating in collaborative meetings, training, and, you know, seeing what's the value, like added value in terms of the outcomes of the consumers that they serve. We will also, you know, we're going to be engaged in a community partnered process. So some of that may change depending on what the community thinks is most important for us to focus on.
That questions. We'll move on to the next one. This question comes from Christina, who is starting a similar initiative in their city. How long has it taken for you to get to this point, and how large is the team working to actualize this plan? And what type of funding has supported this effort? So we have a couple of questions here rolled into one, but it sounds like there's some excitement around starting a similar initiative in another city.
Maybe I'll pass this on to Deborah. I think you have a really good sense of you know, how all this started.
So this really started twofold, having conversations with Dr. Punter about concerns about staff and the impact of COVID on them, both personally and professionally, around their mental health. It was a conversation with Dr. No, who was also expressing concerns. And at the same time, working with Dr. Bean and hearing the passion about the concerns also led us to being able to bring a meeting together to start that conversation. And what I will tell you is that these partners are extremely committed because they have been working on this project for well over 1.5 years with no funding. Doing the surveys, and a nod to our students who have stepped up, both our master's and doctoral students who have really wrapped their arms around supporting the initiative around designing the questionnaires, helping us get them out. Dr. Punter's staff really embracing the project and leveraging their relationships to get people to review the information and share it. So all of that to say that it has been, the funding didn't prompt this. It was the need, it was the commitment of these partners that really drove us to get to this place, so that we're not starting from ground zero, but really having established trust. Because as you would imagine, there are relationships on the line. There's lots of ways that this could go wrong. So I thank you for taking the trust journey with us until we have manifested some resources, and we want to continue to expand that.
Okay, in the sake of time, we only have 1 minute left, so I'm going to go ahead and close out, but I will share the questions that we didn't have time to answer with the research team and give them a chance to respond to those questions, and we can share that as well as the recording and PDF of these slides after today's session. And as a reminder, this is their first time presenting on their research in progress or on their research study that's funded through RWJF and NIH. So follow along as they will present probably once a year, and we'll have some exciting updates, hopefully 2023, which seems wild to be thinking about that far in advance.
Mm-hmm.
A couple of systems for action announcements. We do have a certificate of completion that we offer at the end of this webinar. So as soon as we end today's session, there will be a survey that we ask you to complete just on your satisfaction from today and what you learned and what you plan to do in terms of taking action from the materials that we covered today. And then you can indicate if you'd like a certificate of completion, and we will get that to you in a timely manner. And then this is an ongoing series. So our next webinar will be with another one of the research projects that was funded as part of this wrong pocket problem call for proposal that we released in 2021. And this project is housed at the University of Minnesota, and we're excited to hear from them. So with that, I'm going to go ahead and close us out today. Thank you again to the research team and to Dr. Bean for presenting and talking about the research today. We really appreciate it. And I hope everyone has a wonderful rest of your day.
Thank you.